Okay, we've got one more panel before our break. I know some people are getting restless. We'll have coffee and bio breaks coming up. We have one more panel. Remember, this is our lifespan section. We've gone through early brain development, the workplace years, and now we're going to offer up a panel on healthy aging. And I'm going to invite the healthy aging panel to come and take a seat. This group will be moderated by Dr. Alan Landay. He's the Vice President of Team Science and Professor at University of Texas Medical Branch. He's got over 45 years of leadership in HIV research and immunology. His work has been instrumental in advancing understanding of immune activation, aging, and chronic disease, including contributions to the first FDA-approved HIV blood screening test. That is Dr. Landay. And Alan, I thank you so much for moderating. I'll turn it over to you.
Well, thank you, David. It's really a great pleasure to be here today and moderate this panel. As was said, I've been working and thinking about aging a long time. It's a lifetime opportunity, and what we want to talk today is about healthy aging and introducing some new concepts of health span versus lifespan. That's really a newer concept of living your life to 100, but living healthy without any mortalities or other comorbidities and so on. And what we want to do today is really look at brain health and brain aging in this context and really look at aspects of prevention, therapy, and then finally care. So we'll kick it off with each of our speakers. We want to talk first, and maybe we can ask Andrew to kick it off, introduce himself, and talk a little bit about in the context of prevention in brain health and brain aging. What is he doing, and where does he focus?
Thank you, Alan, for that. And so let me just start out by saying I'm at the Center for Brain Health at the University of Texas at Dallas. We were founded in 1999, so more than 25 years ago. To put this in context, in the 90s, when you do a literature search of the term brain health, we didn't find a single academic paper. So this is really a tribute to the incredible foresight of Dr. Sandy Chapman, that I think many of you know. There's now about 1,200 papers a year that use brain health. We're using the term brain health many times today. So really, on behalf of the Center for Brain Health, a sincere thank you to everyone here who's leading the brain health movement. It's taken decades to come together. Now, at the Center for Brain Health, we're a neuroscience center, but most of our work is actually around the translation of the neuroscience into practical programs. So how do we actually improve brain health for different populations? We have a program for adolescents through the school system in Texas. We have programs for high school students through various community groups. We have programs at Dallas College, University of Texas at Dallas as well. We have workplace programs, so Crystal Sexton works a lot with us. And we have programs for neurodivergent young people. We have programs for the U.S. military, particularly the special ops. Now you might ask, why are the special ops calling the Center for Brain Health for help on what they need to do? It's because they want their brain to perform 1%, 2%, 5% better in the circumstances. And we have programs for older adults as well. And the one thing that we've learned from all of these programs is that you can improve your brain health and your brain performance at every age. I mean, we've talked a little bit about neuroplasticity today. The way we like to express it is your brain changes every moment of every day for the rest of your life. Your brain changes every moment, every day for the rest of your life. And that has immense consequences for how much we can actually do to improve the brain health across the whole lifespan so that your brain span lasts as long as your lifespan. So let me kick it off with those remarks and then get into
Joanne, why don't we follow up with you and your perspective and where you're from. Thank you.
And good morning, everyone. My name is Joanne Pike. I'm the CEO of the Alzheimer's Association. We as an organization have been around over 45 years. We focus in on research, care and support, brain health, and advocacy-related work. I think Andrew said something that's really important to think about, especially in the context of brain health and prevention, which is you can impact your brain at any stage in life. We were able to show that actually with our US Pointer study, which we released last year, where we looked at a structured lifestyle intervention. Houston was actually one of the sites of that research study. And we were able to show that a structured lifestyle intervention that focused on nutrition, physical activity, heart health, and brain activity saved individuals 1 to 2 years of cognitive life. These were individuals who were, for the most part, over the age of 65. And 2 years of cognition matters greatly, especially when you think about not just their life, but the economics of an additional 2 years of cognition. At a population level, that is potentially huge. At the start of the session, we heard that Houston is one of the youngest cities in the country. But the state of Texas is going to be the oldest state in the union in the next 5 years by population age. So the concept of being able to impact your brain at any stage of life matters greatly to the state of Texas. I will end there, but there's lots more we could say about certainly U.S. pointer, lifestyle, brain health, and what that means for Texas.
Great. Well, those are great opening comments. Mitchell, why don't you take us from your perspective, which is, again, from the American Heart Association, and as a neurologist, how do you see where we are and where we're going here in prevention? Thanks.
Sure. Thanks a lot, Alan, and good morning, everybody. My name is Mitch Elkind, and I'm the Chief Science Officer for Brain Health and Stroke at the American Heart Association. By background, for 30 years, I was a stroke neurologist and epidemiologist at Columbia University, and actually when I met Alan earlier this morning, he said, what's a cardiologist doing at this meeting about the brain? And I said, no. I'm actually a neurologist working at the Heart Association, which may seem kind of funny to some of you. But that's because the Heart Association has increasingly recognized that you can't have heart health without brain health, and you can't have brain health without heart health. And so I joined the organization really with the goal of building our programming around brain health and essentially doing for the brain what the Heart Association has done for the heart over the last 100 years. And I think it's notable if you look at, for example, the recent Lancet Commission report where they talked about the 14 risk factors for dementia. 10 of those are vascular risk factors. They're the things that we've been focusing on for the last many decades. And they also span across the life course, right? So I really enjoyed that first session this morning about what's so important about development. We know education is important for late life brain health. In midlife, we just had a session on that as well. Blood pressure is probably one of the most important things to be on the lookout for. Of course, it's a risk factor for heart disease and stroke, but also for dementia. And this year, for the first time, the AHA and American College of Cardiology guidelines for blood pressure management say with the highest level of evidence that we should be managing blood pressure to reduce the risk of dementia. And finally, in late life, addressing things like hearing loss, vision loss are also crucial to prevent and preserve brain health. So we have our own system for doing that called Life's Essential 8, which touches on 4 health factors and 4 behaviors as a way to promote brain health throughout the entire life course. Thanks.
Great. Jim, why don't you take us into what you do here from a local Houston, MD Anderson.
Great. Thank you for having me here. It's been a great event already. I'm the co-director of the Cancer Neuroscience Program at University of Texas MD Anderson, right down the street. And the Cancer Neuroscience Program is one of the priorities at MD Anderson because we believe we can prevent more cancers, treat them more effectively, and prolong quality of life by understanding brain health. That cancer, just the same as what you were saying as you come from it from a cardiovascular perspective, from a cancer perspective, every aspect of the patient's journey, from before the diagnosis to treatment to recovery and life thereafter, is reflected in the health of the brain of the patient. So the better we're able to treat these problems and understand these problems, the more successful we're going to be. My personal research interest is Alzheimer's disease, and I think several of us in this room have committed our lives to working on Alzheimer's. There's no way to treat Alzheimer's disease once you're symptomatic as effectively as you're going to be able to do it in the years and decades leading up to the first symptom. So it's essential that we are able to prevent the problems. And fortunately, studies like US Pointer and others have shown that this is now possible. We now are starting to understand some of these strategies, so we need to get these to the public.
Well, I think we've seen this is a very exciting area. It's multidisciplinary, and as David said, I'm involved in team science, bringing people together from various diverse disciplines to work and integrate. And you can see that brain health and brain aging really takes a village to build that from the prevention side. But now let's think about what about therapies and what are we intervening? I'm an immunologist by training and have thought a lot about the immune system, and as we age, inflammation comes up, how we can prevent that. But we've got some exciting new opportunities with newer monoclonals that are being used in treatment in Alzheimer's. So, Joanne, why don't you kick us off and tell us what's the most exciting things you're seeing from the Alzheimer's Association, and where's the future of our therapies?
Yeah, thank you. And I think just to start off, where are we most hopeful and where do we see the biggest opportunities? And quite frankly, in Alzheimer's and dementia right now, I think what is most hopeful is the pipeline. The pipeline is incredibly robust right now. Right now, there are 192 clinical trials going on with 158 different drug targets. It is more robust than it has ever been historically, and we're looking at targets that are very different than what we have historically always looked at. You mentioned the monoclonal antibodies, and certainly that is a big part of the portfolio and our 2 existing FDA-approved treatments. But right now, only about 15% of federal research funding is going towards monoclonal antibodies or towards amyloid beta as a target. The other 85% is focused on things like tau, inflammation, the gut microbiome, which we heard about earlier today. So these are exciting opportunities that we're seeing and are incredibly hopeful. But you can't get to a treatment target or a research pipeline without accurate diagnostics. And I think that's one of the other hopeful things that we are seeing. We now have plasma blood biomarkers for Alzheimer's, and that will only continue to grow and push into the other dementias as well. And as we are able to accurately diagnose the other types of disease associated with dementia, we're going to see that pipeline continue to grow. So there's huge opportunity right now.
Great. Mitchell, how do you see the therapeutic approaches you're taking? And maybe some of it is around, like you said, the Life Essential 8. How do you see lifestyle interventions, something that we might be able to do in our daily lives to really look at improving brain health, brain economy?
Sure. Well, I'd actually like to pick up on something that Joanne mentioned, which is this huge pipeline we have. But I think apart from individual drugs even, I believe that there's a change in how we think about dementia and Alzheimer's disease in particular, in that we are thinking of it more as a chronic disease that begins way before the symptoms become apparent, and yet we have treatments that may be most effective in those early stages. I think, in heart disease, we check cholesterol in people who feel perfectly healthy, and if it's elevated, we treat them for years. And people have said for many years, in Alzheimer's, if you only start the treatment when people are already experiencing symptoms, the damage is already done. It may be too late, and we've seen that in some trials, and we're very excited to see what's going to come out soon with these early stage treatment trials. So I think shifting that paradigm could be very exciting, using the biomarkers and focusing on treatments and thinking of it again in that sort of cardiovascular disease chronic paradigm, so people are comfortable being on treatments for a long period of time. As a stroke specialist, I'll also add that I think what's really exciting to me is this notion that most people who have a dementia, have a dementing illness, don't just have one disease, they often have multiple. We know the prevalence of stroke, clinical stroke, where somebody shows up in the ER, is about 3% overall. But if you do studies using MRI, about 15 to 20% of people over the age of 65 will have evidence of small strokes on their MRI scan. So the prevalence of stroke is 5 times as high than we've given it credit for. And we know that stroke can lead to blood-brain barrier leakiness, it can lead to inflammation, and perhaps accelerate the neurodegenerative process. So I think we're going to have to shift to thinking of dementia as again, a chronic illness, not unlike heart failure, which has multiple approaches. If you develop heart failure, you will be on at least 4 medications for that. And I imagine dementia will be something similar.
Great. Well, Jim, what's most exciting in your lab today? What are you thinking that will be the next iteration of a new therapy or approach from your work?
Yeah, there's so much to be excited about. And just to generalize what Joanne was talking about from the Alzheimer's perspective, you can imagine a situation that's coming to us soon where from very early age, your genetics will be understood. So you'll know your risk factors for various diseases, and you will be biotyped into certain subtypes of the disease. So we won't treat Alzheimer's or schizophrenia as a single entity, but there will be known risk for you. And then technology will monitor you during your aging process, how you interact with your phone. Someone who's developing Parkinson's may subtly interact with their phone in a different way than someone who isn't. Technology will send this warning to your neurologist, who will order a blood test or some other simple diagnostic to have you evaluated for risk, and then you'll be able to modify your trajectory over decades. This is what's coming, and we just need to be able to identify exactly the technologies that will enable it. And I think we can change the trajectory at huge population scale for the risk for many people for these diseases that way.
Great. And Andrew, from your institute in Dallas, what's the most exciting new areas you're working on and focusing?
Well, we have a pretty simple approach in Dallas compared to all these advanced therapeutics. So the person who has the most influence over your brain health is yourself at the end of the day. And we do what Sally was talking about a little earlier. So Andrew was out there talking about all these intervention programs and adolescents and Navy SEALs and older people. What do you actually do? Our programs all do one simple thing. They teach people some neuroscience, and they teach people some consequences of the neuroscience. And then we try to help people build it into their daily life. So you heard earlier about the 5x5 brain breaks. That's something that came out of the Center for Brain Health on that. So what we do is try to get these interventions, these lifestyle change habits to someone with a little bit of neuroscience so that they understand why they're doing it on that. So we have the simplest, lowest cost intervention. And if you think of this from a brain economy or a brain capital viewpoint, and I'm actually the least important person at the Center for Brain Health because I'm the economist, but from an economic viewpoint, the types of interventions that we do are the lowest cost. If you teach someone how their brain works, it has immense implications throughout their life. Now, it's fantastic to teach at age 3. Listening to Sally about the child growing the dendrites, amazing story. There's a school in Dallas that actually teaches kids neuroscience from about age 3 to age 9, and they shoot their lights out in terms of their performance later in life. But the one thing we've learned is at any age, including my age, I joined the Center for Brain Health at 60, learned some neuroscience, and I managed my own brain health much better than I did earlier in my life on that. So that's our simple approach. So we're going to try to get our simple approach as widespread as possible while we're waiting for the more advanced therapeutics to come in and make it even better.
Well, that's wonderful, because I think we can do maybe some things in our own lifestyles to impact our brain health, brain outcomes. Exercise and diet are very important, and we also have to look at all the other habits that we have. But we're also going to be impacted in Houston, in Texas, in the U.S. with an aging U.S. population, and that's going to change our paradigm. We're going to see more Alzheimer's cases, more Parkinson, more dementia. We're well aware of that, and that's going to change the care paradigm. That's really going to have an impact not only on the patients, but on the care providers, on the physicians, on educational programs. So let me start with you, Joanne. How do you think all of that's going to come together in the future? And how are you, through the Alzheimer's Association and your programs that you're putting forward in the U.S., really going to help all of these different affected populations?
Yeah, I think one of the things to consider within this is that we have to, in order to think about care and caregiving and where healthcare is at, we have to think about it not just with a single physician and a single patient, but a multi-sectoral approach to a system-level change that really looks at where are the inputs, where are people coming from, and how are we incentivizing the level of care that we are delivering to that individual through a individual physician. And so we're looking at it from the standpoint of how can you not only intervene at a physician education level, but also how do you intervene at a systemic level to change how that physician is incentivized to provide quality care, but then also at the state and federal level to make sure that we're thinking about how does Medicare reimburse for things like this. A great example of where we've begun to see some of the policy impacts around this is with the GUIDE model, which is a pilot program out of Medicare that really looks at a comprehensive care approach to an individual who is diagnosed with cognitive impairment or a dementia. And it's not just about the individual that is diagnosed, but also the care partner that is in that dyad and providing care as well. We know that that care partner suffers from greater stress, usually has another chronic disease. And so we need to take care of them just as much as we are the individual with dementia in order to make sure that dyad is taken care of in total. And so Medicare is really looking at how can we look at a different payment model to incentivize the primary care and specialist care connection for this individual and their care partner. We have to take that type of thinking and then expand it to primary care. We don't have enough specialists in the US. We don't have enough specialists globally. I wish we could duplicate Mitch and his neurologist friends in order to make sure that we have the level of care that we need. But the fact is we have to expand into and beyond specialist care to primary care and advanced practitioners in order to ensure that we are going to be able to take care of our aging population within the US and Texas.
Great. Mitchell, you're working with the American Heart Association. How do you see where they're going to go in the future, and what impact can they have on this field? And again, aging is a multi-morbidity. There's more than just the brain, it's the heart, and it's the whole individual. It's really person-centered care we have to deal with in health span and healthy aging. So how do you view that in what you do?
So I would say that at the Heart Association, we have a very similar approach to what Joanne has described about systems of care. And we have developed systems, as I think you were alluding to, for the care of cardiovascular and stroke patients. So we have an initiative that's been going on for about 25 years called the Get With the Guidelines initiative, which includes registries of patients, four of the registries are heart diseases: heart failure, heart attack, cardiac arrest, and atrial fibrillation. One of them is for stroke. So our Get With the Guidelines stroke initiative is actually our largest, which includes over 3,000 hospitals all over the US. We even have hospitals elsewhere in the Middle East and in Asia. And that's over half the hospitals in the US that participate. And it's gotten to the point where 9 out of every 10 strokes in the US ends up in that registry. So we track the data, the quality of care in those patients. We also have specialists who go into the hospitals to work with them to improve their quality of care. And we work on recognition of those sites that are providing excellent care and certification. So as I said, we only have one registry devoted to a brain disease right now, which is stroke. I think it's an easy lift for us to extend that to other aspects of brain care, whether it's dementia, delirium, traumatic brain injury, or others. One other area, couldn't agree more, that we need to have more primary care and others involved, because we just don't have enough neurologists, even in stroke, to take care of the patients. So we have done that in stroke and in other cardiac areas where we educate people who aren't specialists to take care of simpler cases, perhaps. We also employ telehealth, teleneurology, telestroke. So in fact, stroke kind of led the way, because the time window for treatment in stroke is so short that we led the way in use of teletechnology for brain care. And now, of course, during the pandemic, everybody got used to that, and it's well accepted, but we have opportunities to do that. And as part of our venture fund, we are investing in companies that provide the technology for urgent access to brain care. Neura Health, for example, is one of those, and we have others on the way also. So I think there's a lot of change going on, and the systems will improve.
Great. Jim, you work in a cancer center. How do you see what that intersection between brain health, brain aging, and brain economy and cancer, and all the care for the patients, and how that will be impacted in the future? And what more can you do? Because I'm seeing a lot of integration of different systems, different healthcare approaches, and really multidisciplinary. How do you see that in your fields?
Yeah, so I think a lot of people may not have considered it this way, but cancer patients are kind of like the leading edge of brain health in some ways. They're being stressed with their diagnosis. Their brain and their nervous system are being damaged in many cases by their chemotherapy, by their radiation, by their immunotherapy. And then, fortunately, we're creating more and more survivors. But now they have quality of life for the rest of their life to contend with, and we don't have any answers for them. We don't have solutions for their brain health needs afterwards. So this is a very important problem. And I have to give MD Anderson credit for prioritizing brain health as high as immunotherapy, cell therapy, and data science. So it's really a focal point of our institution. Like, how do we make sure that we don't only create survivors, but we give them a reason to survive, a quality of life? There may be more people with chemo brain than Alzheimer's disease in the coming years. So I think this is a very important topic, and I'm really glad that we can learn from what has been pioneered in Alzheimer's disease and translate some of these ideas to care for cancer patients.
Andrew, from your perspective in your centers?
Yeah, I think that one thing that we've learned is no one regrets learning about the brain. Like I give sessions to young people at the University of Dallas College, UTD. I do a lot of workplace sessions. I did a session with some work this weekend at a care home in San Antonio, so an older population. There was a woman in that in the group who was 105 years old, and they care about their brain. So the only strategy and tactics that I think are going to work is to engage the individual who has the greatest interest in making sure their brain works as long as possible. But the ability for the people, at every stage of life, they all want to learn about the brain. And no one, as I said, ever regrets learning the time. But I think the special part with the older population is that it's very important for the caregiver to also learn about the brain and learn some neuroscience, whether it's a paid caregiver or it's a family member. And let me give you a specific example. Sometimes caregivers, or oftentimes caregivers, want to reduce the decision-making that the individual is making. Choose for them, not allow them to make decisions. But I mean, any neuroscientist can tell you that the impact of not using your brain to make decisions is your brain is in decline on that. So by teaching people, the caregivers, some neuroscience as well, these principles, and teaching the individual, the person that is having some challenges, as much neuroscience as possible, that has to be the foundation of these better outcomes on that from our perspective.
I think that raises an interesting discussion I hope we'll have over the next 2 days is what role does AI play in us continuing to use our brain or not? How much are we going to rely on technology? And really, we still need to be able to work with technology now that it's subsumed who and what we are. But let's now go on to our conclusions and our lightning round. And really, everybody, tell us, what do you think is the most exciting thing that's going to be coming up in the next years in your area, in your field? And what do you see as the newest innovations? And we'll start with Joanne.
Thank you. I am impressed that it took us 27 minutes to get to AI in this session. And I certainly think technology is an easy response on what are we hopeful on. I do feel a certain level of responsibility, though, being the only woman on the panel today, to mention that in a healthy aging context, women have unique needs and unique situations, right? We have to think.
Let's give a round of applause. Yes. Yes. Absolutely. Thank you.
And I am really hopeful and thinking a lot about what are those unique needs from a research perspective to understand from a longitudinal side. What do we need to learn from hormone and strength and physical activity that are going to impact a woman's ability to age healthy and resiliently?
Great. Mitchell?
Sure. Well, maybe it's not a surprise that I'll say it's a better understanding of the integration of the brain and the heart, or really the cardiovascular system. And frankly, I would say the brain and the body, the entire body. I think this idea, to get as far as we have in science, we had to focus on the organ that is inside the skull, behind a blood-brain barrier, protected from the rest of the world. But what we've learned through understanding the microbiome and the gut and the relationship of the heart to the brain, the lungs to the brain, the kidney to the brain, the liver, et cetera, is that this is a system, and so we have to think in terms of systems biology. And a big part of that, I think, will be immune system. I know that's your area of expertise, but I think that's where a lot of the excitement is these days in dementia and stroke and a lot of other areas as well. So that's where I'd put my cards.
Great. Jim, your final remarks.
Yeah, the thing I'm most excited about through therapeutics discovery is the huge technological advancement we're about to witness for therapies for the brain, delivering antibodies to the brain effectively for the first time with these Trojan horse shuttle technologies, antisense oligonucleotides that can target specific genes, gene editing perhaps one day, stem cell therapies. All of this is coming together to, it'll change the way we treat brain disease.
Actually, Joanne, I want to let you know that the Center for Brain Health that was built by Sandy and 3 other neuroscience, only built by women. So with women at the forefront of that. I think what's most exciting from our viewpoint is, for us, it's inevitable in 5 or 10 years that brain health will be part of every school, every community group, every workplace, every healthcare system. It's just inevitable. When we just see the exponential uptake of thinking about the brain by everyone, by every group, it's now an unstoppable force.
Well, I'd like to thank everybody. This has been an exciting panel, an exciting journey through where we're going in the therapy and prevention and care. We keep coming back to the gut-brain axis. It's one of my favorites. I started in the microbiome field in HIV and helped start that NIH work there. And I think there's some really great new horizons we can all work towards. But it's a collaborative effort. You can see it on this panel across all the disciplines represented here. It's really going to take a huge collaboration across many disciplines, and I think that's the very exciting part of these next 2 days. So we'll end there, and our time is up. And we'll now go to break for 15 minutes. So you have a 15-minute break. Please enjoy.